This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Hello, my name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Sami Walid, who is the Medical Director of Research at the Georgia Neurosurgical Institute. Welcome, Dr. Walid.
Thank you, glad to be here.
And so let's talk a little bit about how you've come to this part of the world. Your initial home was where?
Syria, Middle East.
In the Middle East? And
a town called Latakia on the Mediterranean.
Yes, and then what happened then?
I finished medical school in Syria in 1996.
Yes.
And my father wanted me to come to America to get certifications. So I came to America, I passed my exams, and I got the ECFMG certification
and then I think,
in 2001.
Right, and also I think along the way you picked the PhD up, is that
yes,
correct?
and because I have also some Russian roots from my mother, it was easy for me to go to Russia and to get into Kuban State Medical University, where I spent 5 years.
Yes.
And I got the PhD in physiology.
Well, great. And so, yes, you have a pretty good background to do research, and you've been with us, and we have lots of different kinds of research projects that we've undertaken together at the Institute. And tonight we can talk about many different things, but I think it would be useful in this climate, this economic climate, to talk about some of our efforts to improve healthcare efficiency and decrease healthcare expenses. And we've done a lot of inquiries on those lines, have we not?
Yes, exactly.
And we've looked into different things, and I think what we'll do now is start with a little video, if that is possible. And we're going to show some of the just a quick little snippet of some of the things we've done, and this will be kind of a little slideshow, which I think is getting ready to hatch out. So we'll just be awaiting that. And this is going to be some of a rendition of some of the things that we've tried to accomplish over the years, and we're almost ready for that. Is that correct? As we sit here, so I think they're about to start. Tonight we're just going to go through a few slides for the purposes of discussion about our efforts to decrease the cost of health care. So we've done some work at our institute on improving physician efficiency, and that should save money. And this is just a little rundown of the extraordinary amount of money that goes into our national healthcare expenditures. This is $2.3 trillion. That's just an unbelievable number, amounting in the world to about 6 or 7% of all of the money expended on our planet for anything. And you can see a substantial amount is for hospital care and physician services. And obviously, this is just not a sustainable expenditure of national healthcare resources. And our big mantra at the Institute is to have clinicians involved as opposed to having external mandates or rationing. So it's the doctor's job to get involved in this process. And we can think of healthcare just like an airplane. We want to have people get on the seats, be effectively treated, and then get off the airplane in a smooth fashion. So we can divide that into it's preoperative screening, operation, and discharge. So preoperative screening turns out to be a big important thing in healthcare delivery. And some of the work we've done involves comorbidities, and these are things like having diabetes or hypertension, and that the impact these secondary disease processes have on the patient's general stay in the hospital. And these comorbidities affect costs substantially, and it's one of the things the United States government is looking into, but this just gives us a quick look at that. And these comorbidities have a major additive impact on the one's stay in the hospital. So we'd like to identify these comorbidities and then do something to diminish their cost. Some of these comorbidities are occult. That means you can't really easily determine them. So that means that patients that are undergoing spine surgery or any kind of surgery need a very careful preoperative evaluation. And it can be said that these comorbidities increase with age and body mass. And what we're seeing in our country is an explosion of obesity, and we also have a population that's living longer. And these two factors together increase comorbidity and thus the cost of different kinds of surgeries. And these graphs just kind of, they're somewhat occult, but they indicate that comment. And so what we want to try and do is screen for different kinds of surgery, spine surgery. We want to make sure that we don't miss any of these comorbidities and they're effectively treated before the patient has surgery. And this graph just kind of quickly demonstrates that. And we can also make the comment that if we do patients that are inpatient as opposed to outpatient, the costs are much less. And we should find a way to get those patients in an outpatient environment, and we can treat them in a less expensive fashion, and presumably without any additional complications. And that's one of the things we're doing at our institute. I think many other people do that as well. Some of the things that we have to pay attention to intraoperatively, there are lots of things that we monitor. But we can look at this particular graph just shows the impact of costs on different kinds of anterior discectomy infusions. That's a neck operation, whether we use cadaver bone or the patient's own bone. And this seems to indicate that using cadaver bone is somewhat more expensive. Another thing to do is just looking at the impact of different kinds of methodology for our back operations. And we can see that in some circumstances when we put a drain in a patient's back after a large lumbar fusion, that can increase the cost, and presumably that's a factor in the decision whether we should do that or not. Of course, patient welfare comes first, but we need to consider cost as well. Just like getting off the airplane quickly and getting your luggage, it's important to have effective discharge. One of the things that goes on is we've examined our spine cases to see if the association with an infection and postoperative temperature. And as this graph indicates, we can see that low-grade temperature is not associated with infection and thus should not delay discharge. That's a big thing. This is the kind of thing docs need to be paying attention to. And if we can effectively discharge patients, we can save an enormous amount of money. And this just shows one of the things we do are writing orders, postoperative orders quickly and getting them on the chart so we can get the patients out soon. And the savings is enormous. Per patient, we calculate that depending on the orders, thousands of dollars can be saved just by the physician paying more attention to trying to get the patient out of the hospital sooner. And one of our big mantras at the Institute is the Hippocratic Oath, which binds the physician to his patient to preserve patient welfare. And one of the things we might think about doing is expanding that Hippocratic Oath to turn the physician more into a guardian of the nation's healthcare resources, as opposed to letting the government or insurance companies do that. And this is just a picture of some of our gang at the Georgia Neurosurgical Institute. We're at a conference early in the morning, you could see, and in Fine Fettle. And thank you. So it's good. All right, great. So that'll be. Okay, well there we are. We've been through a pretty quick run around the bases, and I think we can just spend a little time trying to talk about what we can do to decrease healthcare costs. And Dr. Walid has been intimately involved in this, and some of the difficulties I think physicians face when they try and do this. There are a number of them, but one is just getting access to what things cost. So the way the system works in the United States, it's in the whole healthcare apparatus, it's very difficult to really come to grips with what a particular instrument might cost or a particular bandage. And there's not an incentive system that's in the system to encourage a physician to minimize cost. It's a very kind of arbitrary efforts are underway. So what we've just made some efforts to look into that. One particularly interesting thing, and I think Dr. Walid was involved in extracting this data, is we reviewed, there's something called PubMed, which basically details all of the peer-reviewed papers that appear in the medical literature. And this is a very powerful thing influencing physicians. So physicians are influenced by many things, but a peer-reviewed article really is very powerful. And if a particular treatment is advocated in our medical journals, then we pay a lot of attention to it. And outcome analysis turns out to be a big thing. So physicians are going to often espouse a new treatment based on the articles that have appeared. And when we looked at, it's not too hard to do with a computer, we looked at thousands of articles that had been published over the past 20 years in a variety of different specialties, orthopedics, cardiovascular surgery, neurosurgery, and we attempted to see in the outcome analysis how frequently mention was made of any kind of economic issues, how much things cost, and the numbers were shockingly low, on the order of 2 to 5%. So only in about 1 in 20 articles were the physicians aware of what things cost, and do they publish what things cost. So many times treatment protocols are being put in place without attention to these numbers. So that's a big deal. And one of the things that we'd like to see happen, at least at the Institute, as we look at the future, is in different localities around the country that physicians be encouraged to get involved in this process to minimize costs. And it requires collaboration with hospitals and with insurance companies to understand exactly some of the dynamics of cost. Now, Dr. Walid, would you like to comment some on different aspects of
regarding the
cost
awareness among physicians? Yes, in the last 50 years there has been an increase in healthcare expenditures in the United States. This also correlated a little bit with some increased awareness among physicians about cost. The problem is this correlation is not very strong. If we draw the lines that represent each of these two variables, they don't parallel each other. We need to promote awareness among physicians about the cost of healthcare, and we need to balance our care regarding cost and regarding the patient interests.
Well, of course. And so one of the things that that's important in this conversation is we can, as physicians, can never advocate anything that minimizes patient outcomes. So I think that's axiomatic with the Hippocratic Oath, the idea that physicians are dedicated to their patients, and they want the best possible outcome for them. But I think one of the things that's occurring in our country is, as our slide showed earlier, healthcare expenses are absolutely unsustainable. There's just not enough money to continue to pay these costs, and we have this enormous national crisis that's about to appear. And there are all kinds of different things that are advocated, but at least locally, what some of our research has uncovered, or at least we have put our foot in the water, is that there are lots of ways that can be formulated to preserve a good patient outcome and also diminish expenditures. So like we mentioned, early discharge from the hospital. I mean, just getting the orders written soon enough. That has, just little things like that play an enormous role. And this kind of creating this kind of culture, I think, is particularly important. And one comment I might make, as we're having our little interchange, is that there's a good way to get these things accomplished. One of the great crises that faces the American healthcare system is there's not enough money for medical education. And if you look at the money that's expended for medical education, it's pretty much of a flat line. And there's just not any great, there's no great cornucopia of shekels being put there. The government and all of the players have kind of frozen things on a flat line. At the same time, we have this enormous expenditure for healthcare is increasing so much. So one thing to do would be to have physicians really, really carefully trained and to understand what things cost. And that if the government were to spend some additional money to promote that kind of thing, it would be a great step forward. And I think a lot of these I guess, ideas have been left out of the national dialogue that's occurred in the whole healthcare apparatus. And this is one of the things to be said, I think, for physicians, is that if they don't do this, if they don't start to pay attention to the cost apparatus, and what's going to occur is there's going to be some kind of pseudo-rationing process that's put in, and this pseudo-rationing process will cause very inefficient healthcare delivery, and then the patient's welfare will be jeopardized. And these, I think we had a slide earlier, we talked about the external factors that might impact a physician's decisions about what to do for his patient. So the government or the insurance company may say, well, you can only do this, you can only give your patient this particular treatment because we've decided that's the way to do it, and the physician hasn't had a role in that discussion. And I think that's an extremely important thing to try and do, and we're trying to take some steps to do that. And we have lots of inquiries underway, do we not, right now,
Yes,
Dr. Walid?
yes,
we're
yes.
looking into a lot of different issues here.
As the slides show, we try to study different factors that affect costs from different perspectives, preoperatively, intraoperatively, and postoperatively. There are some factors that are modifiable. There are factors that are modifiable where we can intervene and save a lot of money. We just need the will to do it and the incentive to do it.
So one of the important things I think that maybe the public should recognize is as we try and diminish healthcare costs, one of the greatest ways to do that is to minimize complications. So if we have a patient interchange and we're treating a patient and a complication occurs, that turns out to be an extremely costly thing. So minimizing complications is a huge, important thing to do. And it saves a tremendous amount of money, and it's worth an investment to prevent those complications. One of the slides that we showed sort of en passant earlier were the patients that were the comorbidities that existed in patients receiving spine surgery. So if a patient has lots of things that are wrong with them and they're facing a spine surgery, all of those things need to be dealt with prior to operative intervention. So the preoperative screening and very careful attention to getting a patient exactly ready for surgery will minimize complications, and it'll improve patient outcome, and it'll lower the expenses of the whole process. And that turns out to be a big deal, does it not?
Yes, cost effectiveness here comes from screening all patients preoperatively, paying a little extra cost preoperatively in order to decrease the final cost by decreasing complications, improving outcome, decreasing the risk of litigation. So here comes some economics in this matter. Preoperatively, when we screen patients, patients as a cohort, they follow the normal distribution. So most of the patients don't have severe comorbidities. By age 60, most patients may have 1-2 comorbidity. But the extremes, those that are above 95 percentile, those are the patients we direct our attention to, and we need to find during the screening process, because those are the ones who are more likely to have postoperative complications and cost more.
So I mean, not only that, but they wind up with their outcome. The two go together. So if a patient has a bad outcome, there are lots of bad things that happen. The patient themselves suffers. No one wants that to happen. And it drives the cost of healthcare up. So we have to pay a lot of attention, just because if we don't do something about this, then there won't be enough money there to do needful things that people need.
Yes.
I mean, and some of the things, I guess, that we've chanced upon, or we had a slide about this, is the is in many cases a low-grade fever after an operation is just not a big deal. But what occurs, so this particular fact could be an argument to not keep the patient longer in the hospital. And that would be a tremendous saving. So if we can understand what are the reasons to keep the patient in the hospital, or in our analogy was on the airplane longer, I mean, trying to minimize that turns out to be a very important issue. We talked a little bit about some of the factors that influence decision making, and there are lots of things that are in the public dialogue now about what is going to have a particular decision made or not made, and it's a very complicated matrices as to what happens, and as I said, there are lots of complexities. People will say in one state a particular kind of treatment is employed, and another state a more expensive treatment is employed with no particular any outcome differences. So when these facts appear, it's very important that appropriate research be done on the subject. And the people to do the research are the physicians involved, and they just need to have they need to be encouraged to do that, and they need to have access to appropriate data. It's often quite difficult to get that, is it not? I mean, if we try and conduct studies, it's very hard to get what things cost.
Physicians are at the center of the healthcare system, and they need to have access to cost data and to be involved in cost analysis, and not leave this to administrative staff or bureaucrats. We need to take initiative as physicians and clinical researchers in improving the efficiency of the healthcare system, because we need to keep this healthcare system the best in the world.
Well, I think it is, and I mean, we could discuss that as some of the outcome data that we discuss what's good and what's bad about the American healthcare system. And it's maybe a time for another conversation about this. But in the debates that occurred, I guess in the last electoral cycle, there are lots of stories about the American healthcare system, and I think a lot of the figures that were produced were, I would say, inappropriate, and they didn't really reflect the excellence of care that people can obtain here. And there are lots of things that influence our healthcare data, and a lot of it involves patient cooperation, and a lot of this is a lifestyle choice that patients may or may not make. And so there's a lot of deserved freedom and liberty here. People can often make bad lifestyle choices, and it diminishes our national healthcare statistics.
Well, these are side effects of prosperity. As number one country in the world, the best longevity, economic prosperity. Of course, we can expect some side effects like increasing obesity, for example, or comorbidities. But still, everybody knows that the American healthcare system is the best in the world. It is expensive, right? But how can you expect to have the best healthcare system in the world and not be expensive? So,
well,
there's no contradiction in that.
Right. An interesting statistic is, if you want, I mean, we sort of touched on that a little bit, the amount of money that's basically spent in the American healthcare system. The number we presented was $2.3 trillion, which that's a tremendous number, but that's more than the gross national product of France. So if you can imagine the French, that's a lot of fromage, I mean, meaning cheese. I mean, that's a huge amount of money that's spent every day here. And just if we could make that system just a little bit more efficient, national prosperity in these difficult times would rocket up. And there are lots of ways to do that. We've talked a lot about economic issues in regards to emergency care and the trauma system. That's a topic for another time. But if our emergency healthcare system is made more efficient here, it causes tremendous economic savings. It's a great investment. And when we consider the American healthcare system. I think we have to think of it as an investment. So there's money that's being put in there, and I think we must say very inefficiently, but it produces better health, longevity, more vigorous people, and people that can be productive citizens. And it were the investment taken away and the health of our citizens declined, then the gross national product would decline. So I think that's, as we consider the amount of money spent on healthcare, we have to realize it has a substantial economic benefit, and that other countries profit from the research that we do here, the innovations that we've had.
Yes,
and
exactly.
It's very important to preserve that type of arrangement. And I think it's particularly important to make certain that these benefits are widely distributed. Mm-hmm. One of the things that I think it's maybe time for another discussion is what happens in the matrices of the American healthcare system is that some hospitals have a particularly prosperous group of patients there. So maybe they all have insurance, and that hospital is going to have, they'll have enough money to provide really cutting-edge treatment. Another hospital that has a relatively poorer population, maybe without insurance or Medicaid patients, won't have enough money to really render the same kind of care. And because there's a variance in the care, and the hospital that doesn't have as much money may wind up with poorer results, worse outcomes, more complications, and society will have to pay for that. So to get that hospital to have enough money is going to be a good economic decision, and that's one of the tasks that's out there, is
Mm-hmm.
discover these inequalities in healthcare. It's going to be a very important thing. I think, Dr. Walid, you've seen other countries, and one of the things that must strike you as you see the American healthcare
Yes.
system is the abundance of resources. It's just absolutely extraordinary, is it
Yes.
not, compared
I
with
can
other
say
countries?
something about that. I've been to many places in the world. Everybody listens to what American researchers say. So why is America number one? Because we Americans do research and everybody else follows. So research is what makes us different from others. Okay, everybody can do an appendectomy, but doing research that can lead to innovations and minimal invasive appendectomy, for example, this is what makes us, I'm talking about Americans, at the front line, because you do first and everybody follows. And this is all thanks to research. And research is not a cheap pleasure. It requires dedication, resources, and hard work. That's why just a few countries lead the world in research and medical research and in other fields also.
Well, I mean, so that's we'll blow the trumpet for the USA. Certainly, I consider it still numero uno, and I'm glad to hear you share that opinion. And we need to continue to do our work here and see what we can do to make things more economically efficient. We have a lot of projects that are underway, and we have a number of people that are helping us. I think all together, I'm trying to count the number of fellows. Maybe we'll have them on and sort of let them talk about what they're up to. But I think right now we have 4 people besides yourself that are actively involved in research. And that's one of the things we've done for many years. We have all kinds of different kinds of research projects that are underway that I think are pretty interesting, and we hope to continue to do that in the future. So, Dr. Walid, I'd like to thank you for being here tonight. We'll continue our dialogue as we're just about ready to sign off. I have a few seconds left just to say that I hope that as we go forward these next few years, we can all collaborate, and it's not something merely for physicians, it's for everybody. Trying to come up, it's part of our national identity to try and to preserve our healthcare system, to make it the best possible system in the world as it is now. And there are lots of complications there in doing that. So I think it's just getting about time for us to sign off. And so Dr. Walid, thank you for coming, and we'll see everyone next week. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.